Hi, Sarah. Good evening, guys. How are you guys doing today? Great. Awesome. Awesome. I see many of the names are familiar because I know, or many of you have already contacted me in the past. And I'm a little excited for this class because this is the first time we are doing a free webinar for NPTE students. We have done it in the past for PCE students. We also teach the PCE students. Now, those of you who don't know what is PCE, it's the Canadian license exam. We are involved in many license exams. One of them is NPTE, PC, and DHA2. How's the day going, guys? What are the plans for weekend? Thank you, Chase. Reading. That's the plan. It's a payday, I guess, for many of you. For me, at least. Study. Okay, that's awesome. That's how hardworking students are. They study even on the weekends. I'll just make the chat box a little bigger. And we'll start in 1 or 2 minutes. I'm just waiting for a few more students to log in, and then we'll start, okay? All right. So in the meantime, I'll give you my brief introduction. Many of you don't know me, and I'm not very popular on Facebook because I'm not very active on Facebook. Okay. Or before that, how is my accent? Because I see many of you are internationals attending the class over there. So are you able to understand what I'm talking clearly? No problem. Awesome. You understand me well? Awesome. Good. It's manageable. All right. So I'm Ankit, and I did my bachelor's from India, and I came to States and I did my master's sometime back, and then I completed my doctorate in physical therapy. And I've been teaching, I was teaching assistant in my master's degree. I have some experience of teaching from my master's, and then I've been teaching for NPT for almost 4 years. So I used to work for somebody else, but then I thought there is a need for something else. So I started this class. Many of you might be knowing me because I was talking to one of the students, and she told me she knows me from four years back because I was somewhere else back in the day. That's me. And the reason I said I'm not very active on Facebook is like I'm not very popular on Facebook is because I'm not very active on Facebook. And all my time, like I work as a physical therapist in skilled nursing facility. So my full time, 8 hours goes there. I come home, I teach, and the day ends. Next day again, go to the nursing home, work with those old patients. That's a relief sometimes. It's like refresher. Come home, teach, done. So no life. Okay? Some of the students tell me that you don't have a life. But you know what? Life is to make others satisfied. Okay. And I feel it every few months. Okay. All right. So we'll start, and I'm going to teach you some topics, like one topic. And the idea behind this free class is to tell you how we teach. Okay. How we teach and why we have such a huge number of passing rate, why we huge number of students passing the exam. And since we are the classes are expensive, so a lot of students are not able to try us. That's why we decided to give you a free class to make you understand what is the requirement for NPT and how you should be studying and how we teach. Okay, I'll start with a topic, and after me, excuse me, if we have time, we'll surely have time. So Pooja, who's a member of our team, she will be teaching you some topics. Okay, she'll be giving you some questions. All right. Okay, so I'll start with something called Trendelenburg. Okay, that's one of the major weak area. And the reason I'm teaching this is because this way I can explain you how you can connect the whole body, how the whole body can be connected with just one muscle weakness. Okay. All right. All right. So we'll start with Trendelenburg, and then we'll go ahead with scoliosis, leg length discrepancy, and how we fix this problem, those kind of things. Okay. All right. So we'll start. Okay. How is the voice on your end? Am I too loud on your end, or is it normal? Should be normal. Okay. Good. Awesome. Great. Okay. So Trendelenburg, you all know that. You all know Trendelenburg is a weakness of gluteus medius muscle that causes various problems. So let's say this is your right side and this is your left side. Imagine this individual is right and left. Okay. So in gluteus medius, what we have studied so far is gluteus medius, if it goes weak on the right side, left pelvis drops. And I was like always lost how this happens. Like right gluteus medius gets weak, left side drops. The easier way is like right gluteus medius goes weak, so right pelvis goes up and left goes down. Okay, that's the easier way of understanding that. But we have to understand when that happens, when gluteus medius goes weak, it causes imbalance over there, imbalance in muscles. Okay, so over here, if you see, do you know the name of this muscle? That's Quadratus Lumborum. Okay, Quadratus Lumborum, and this one is your gluteus medius. Okay, now the purpose of Quadratus Lumborum is, do you know the origin insertion of Quadratus Lumborum? It originates from your iliac crest, okay, and it goes up and insert into the transverse processes. Okay, it goes up and insert into the transverse process, vertebra and the ribs. Okay, and the ribs too. So originates from the iliac crest, goes up. So the purpose or the function of iliac Quadratus Lumborum is to pull the pelvis up, hiking. Okay, hip hiking. Then we have another muscle, that is your gluteus medius, that originates from the pelvis and inserts at the trochanter. See how the line of pull is. Gluteus medius originates from the pelvis, goes down and insert on your greater trochanter. Okay. So what happens? What's the function of gluteus medius? To pull the pelvis down. To pull the pelvis down. Okay. That's the function. And the function of Quadratus Lumborum is to pull the pelvis up. Okay. To pull the pelvis up. Now both of them are antagonist to each other. Both of them are antagonist to each other. And Quadratus Lumborum, when you're standing up, Quadratus Lumborum is trying to pull the pelvis up, and gluteus medius is trying to pull the pelvis down. So normally what happens is your pelvis remains in the center. Okay, if both of them are equally strong, your pelvis will remain in center. But if any of them goes weak, okay, the other one will pull the pelvis in its direction. Okay, so if your gluteus medius over here goes weak, Quadratus Lumborum on the same side gets shortened. Okay, it will pull the pelvis up. Your pelvis will go up. All right, so they're kind of enemies. They're like, they hate each other. Okay, if you'll go weak, I'll take the advantage and I'll pull the pelvis up. It's like that. Those jealous friends, okay, who don't like to see progress in any of them. So that's how your Quadratus Lumborum is. Okay, they will pull the pelvis up right away. Now, so the point is, when your gluteus medius went weak and Quadratus Lumborum is shortening, when Quadratus Lumborum gets short, what happens is the function of Quadratus Lumborum is side bending of the trunk also. Along with hip hiking, it also bends your trunk on the same side. Okay, it also bends the trunk on the same side. So what happens is, in that situation, if I try to bend on the left side, okay, if I try to bend on the left side, I'll feel some tension on the right. Okay, so I'll avoid going on the left side because I feel some tension. And the day goes on, so whenever I'm sitting also, I'll lean on that side, or standing, I'll be leaning on that side. So basically what I'm doing, I am promoting your Quadratus Lumborum tightness. further gets tight. If I bend on the right side more, it gets shortened more. And if quadratus lumborum gets short more, that further weakens up your gluteus medius. Okay, is that clear so far? Let me know if I'm going too fast. Let me know. All right. Next. So I'm slightly bending on the right side. Now what happens next? Who's the antagonist of your quadratus lumborum? Who's the antagonist of your quadratus lumborum? Other than the gluteus medius on the opposite side, it's the opposite quadratus lumborum because quadratus lumborum causes bending on the right side. Okay, right quadratus lumborum causes bending on the right side. So that stretches the left quadratus lumborum. So the left quadratus lumborum gets further weak, getting stretched. So left quadratus lumborum gets weak, right quadratus lumborum gets tight. Now on the left side, you have gluteus medius too. So there are two enemies. So what happens to the pelvis now? Where will it go? That will be pulled down by gluteus medius. Okay, that will be pulled down by gluteus medius on the left side. All right. Right, awesome. So that's the mechanism between gluteus medius and quadratus lumborum. So, and it works in a cross. If you notice that right gluteus medius and left quadratus lumborum, they have gone weak. And your right quadratus lumborum and left gluteus medius have gone tight. Okay, so that's the whole circle. That's the whole circle. I'll just repeat it quickly. This went weak, so right quadratus lumborum went tight. Okay, now I kept bending on the right side, so my left quadratus lumborum went weak, and right or left gluteus medius went tight, so pelvis dropped. Now next point is if I'm bending on the right side, do you know any of those side flexors of the trunk? Which are the side flexors of the trunk? Old students, okay, strictly new students. If you are a student, please stay away from the chat box, okay? So new students only. Obliques, and new students only, strictly. Those who have watched the lectures, please, okay, give new students some chance, okay? All right, so obliques, that's awesome, obliques, okay? So I'm bending on the right side, so my right quadratus lumborum is getting tight, which is allowing my obliques, which is also a side flexor of the trunk, to get tight. Okay, so my internal and external obliques, they get tight. Okay, internal oblique primarily. There is one more function of obliques. Do you know what is that? Yes, Robert, rotation of the trunk. Okay, so if I'm bending on the right side because of shortening of quadratus lumborum and obliques will rotate me to the left side, and right internal oblique causes left rotation. So bending on the right rotates me to the left. Okay, bending on the right rotates me to the left. Okay, easy. So that is the reason if I bend on the right side because of QL tightness, and now I'm rotating to the left because of obliques also working now. They're also getting tight. Once the obliques get tight, I'm rotating to the left. Okay, next. Now I'm rotating to the left. So my pelvis also rotates to the opposite side. So right pelvis will start rotating to the left side like that. Okay, so far clear? Now what happens next is your right quadratus lumborum is so tight and obliques are so tight. What happens? Your pelvis goes up. Pelvis goes up. When my right pelvis goes up, my right foot also goes up. Okay, basically now my right foot won't be touching the ground. It won't be touching the ground if it is a severe weakness of gluteus medius. So right pelvis goes up because of weakness of gluteus medius and all, and tightness of quadratus lumborum. And left pelvis drops. So when my right pelvis has gone up, my foot won't be touching the ground. Now, I'm not going to walk all day without touching the ground. I have to touch the ground. Okay. So what are the different options? What are the different options? One of the option is, what should I do? Different options. Hiking, plantar flexion, lean to the right. I can lean to the right too. Yeah. Toe walking. So basically how to touch the ground. I can either supinate the foot or I can plantar flex the foot to make it longer. Okay. Because I'm not able to touch the ground. So what I'll do is I'll supinate, invert, or plantar flex. Those are the two mechanisms. So on the right side, I'll either supinate if it is a short gap between the foot and the ground, or if it is huge discrepancy, I'll have to plantar flex and supinate both. Okay. So that's happening on the right side. Now, the right pelvis was up. That's why I had to do that. Now my left pelvis has dropped down. Okay. So my left pelvis drops down. So what happens? Foot also goes down. Foot also goes down. Okay. So when my foot goes down, what happens? I start to lose the arch of the foot. I start to lose the arch of the foot. Okay. So when I lose arch of the foot, when I lose arch of the foot, my foot goes in pronation. Foot goes in pronation. Okay. Foot is going in pronation on the left side and it's going on supination on the right side. See how opposite it is? On the left side, it's going in pronation because my foot is, there's a lot of weight bearing happening on the left side. Okay. Because it's touching the ground too much. And right side, I have to supinate the foot or plantar flex the foot to touch the ground. See the difference. Okay. That's like amazing. So you have to understand now when my foot supinate on the right side, which muscles goes weak? Pronatus, like basically your everters. On the right side, everters, that is your, which are the everters on the right? Which are the everters? Peroneals, right? Peroneal, longus, and brevis, they go weak on the right side. Okay. And on the left side, your supinators goes weak because your foot is going in pronation. Your foot is going in pronation on the left, so supinators goes weak. On the right, pronators goes weak. Imagine like what's happening just because of the weakness of gluteus medius. All this mess has happened, right? Very important. Yeah. So this is very important. Is that clear so far? Glad, glad, glad. Now the next part is the mechanics is clear and everything is clear. So what should I do now? Let's go through the muscles. It has gone weak and tight. Let's quickly go through the muscles. Your gluteus medius on the right was weak. So which is an antagonist to gluteus medius? What muscle is an antagonist to gluteus medius? Yeah, other than quadratus lumborum, is there any other muscle? Okay. Now gluteus medius is primarily, what is the function of gluteus medius? Abduction. So adductors will go weak, right? So adductors will go tight. Adductors, if you come at the leg. So if your gluteus medius is weak, automatically on that side, adductors goes tight. Okay, adductors go automatically go tight. So that's one of the muscle that you need to fix. And you know what happens in the foot? Inverters goes tight. And your quadratus lumborum goes tight on the right side. On the left side, you know quadratus lumborum, weak, right? Gluteus medius. What happens to adductors on the left? Because gluteus medius goes tight on the left, adductors goes weak on the left. And in the leg, what happens? Your everters gets tight and inverters gets weak. So this whole mechanism has happened, and you're bending on the right side. You're bending on the right side. Okay. I'll quickly show you the muscles getting tight and weak. After that, we can move on. Okay. These are the muscles. Muscle imbalance. Can you see this? Same thing. the same cross happens. Okay? The muscles that are weak on the right are tight on the left. Okay, and muscles that are tight on the right are weak on the left. So they're kind of taking the revenge. Okay, right, left, they're kind of taking the revenge. I will see you on the left side. It's like that. So that's the whole mechanism. All right. So how are we going to fix this? Before that, taking it to a different level now. We are connecting the whole body now from how pelvis or gluteus medius is causing problem in the foot. Now I want you guys to think that if my right gluteus medius is weak and my foot is supinating on the right and pronating on the left, what are the different problems that can happen now? What are the different issues that can happen? Can you think throughout the leg? Okay, scoliosis is one of them. Okay, scoliosis is one of them. Gait deviation, hiking, back pain. Okay, let's come on the left side. Okay, pay attention. Let's come on the left side. My left foot is pronated. So tell me the problems associated with left foot, pronated left foot, and too much weight bearing on the left side. Can it be genuvalgum? Because my abductors are tight. So is it possible? Genuvalgum? Abductors will not. In genuvalgum, your femur goes in, right? In genuvalgum is like this. Knock knees. Your femur goes in. But if your abductors are tight, how can your femur go in on the left side? Not on the left side. It can go in on the right. Okay, if you meant right side. So tell me the problems of the foot or the leg on the left side. Tibial torsion. But do you think patient will come to you for tibial torsion? There has to be some real life problems. Fasciitis. Yes, fasciitis. So your foot will be pronated or flat foot. Flat foot. When your foot is flat, your arch goes away. Your foot arch goes away. Okay. So that is stretching your fascia. And that causes some tear at the origin of the fascia. Okay. So you'll have plantar fasciitis. Any other problem? Awesome. Sandhya is saying Achilles tendinitis. Because of the pronated foot, this individual will have Achilles tendinitis on the left side. Achilles tendinitis, fasciitis. Yeah, stress fracture, those kind of things happen normally when you have osteoporotic leg and when you're doing a lot of weight bearing. So that can happen in the old individuals. Bursitis, which side and which bursa? Which bursa will get inflamed? Dark red is tight. Dark red Israel is tight. Light red is weak. The brown one is weak one. Dark red is tight one. Okay. Think about shin splint. In shin splint, what happens? Everted foot. Okay. Everted foot. That causes shin splint. When your foot is pronated, that means your tibialis anterior will be getting stretched all the time. Okay. So when your tibialis anterior stretches, that means it's weak in pronated foot. So that leads to shin splint. Okay. What else? Flexor Hallucis tendinopathy. Have you heard of this thing? Flexor Hallucis tendinopathy. Do you know where it is? No. Now, flexor hallucis tendon is present on the medial side of the leg or foot, and it is responsible for plantar flexion and inversion of the foot. Okay, plantar flexion and inversion of the foot. So let me write it down, or let me just show it to you. That's slide. Plantar fasciitis, shin splint, tibialis anterior weakness. Okay, because your foot goes in pronation, so tibialis anterior weakness leads to anterior shin splint. And now, have you heard of posterior shin splint? That happens because of tibialis posterior weakness. Okay, so both of them can happen here. Flexor Hallucis tendinitis or tendinopathy. That's the muscle that supplies your great toe. That is the muscle that supplies your great toe, and that is responsible for plantar flexion and inversion of the foot. So when you have everted foot, you will have pain on the medial side of your foot, on the medial side of the foot, because that tendon goes from the medial side into the great toe. Okay, so patient will complain of pain over there. And if you don't know the mechanics, like how somebody having gluteus medius weakness is complaining of foot pain on the medial side, we never think like that, right? And those things are very important. Do you know tarsal tunnel syndrome? What is that? When your foot is everted, there is a tarsal tunnel, the nerves on the medial side, posterior tibial nerve, it gets compressed. Okay, it gets compressed, and that will lead to tarsal tunnel syndrome. So I developed problem in my gluteus medius on the right side, and now I'm having these problems on the left leg. Interesting, right? Right, next, some of the problems. Now, there are many other problems. We don't have much time to discuss about that, but there are many other problems, okay? Yes, Anserine bursa, that can happen, okay, on the right side. On the right side, some of the problem are like trochanteric bursitis on the right. Why? Because your greater trochanter, when your leg goes in, when your femur goes in on the right your adductors are tight. So when your femur goes in, I'll show you that slide. Okay, this one. So think, adductors are getting tight. Basically, it's going inward. When this part goes in, your proximal femur, the greater trochanter goes out, right? Trochanter goes out. Femur goes in, trochanter goes out. When trochanter goes out, there is something called trochanteric bursa over there. That gets compressed. Okay, so you'll have bursitis, trochanteric bursitis over there. In this situation, when your femur goes in, initially patella goes in, but then what happens? Patella can be pulled out down the line because of IT band. IT band develops that tension that pulls the patella out. Patella gets pulled out. Now patella is present on the lateral condyle now of the femur. So when you flex, extend, patella is moving on the lateral condyle. So what happens when your patella is moving on the lateral condyle? That leads to a problem. That problem is called patellofemoral syndrome, patellofemoral pain syndrome. Okay, when your patella moves on the lateral condyle. On the right side, we are having these problems. On the left side, we had some other problems. And since your foot is in inverted position, you're more prone to develop ankle sprain, lateral ankle sprain. So interesting part is I developed weakness in my gluteus medius on the right, and I'm having pain in left and on the right just because of that muscle. Very interesting, right? So how do I fix it? How do I fix it? Do I start, like if I have foot pain, should I fix the foot pain or should I fix the main cause? We always fix the main cause. We always fix the main cause. But you have to understand first what is the main cause, because patient will not come to you due to weakness of gluteus medius. Patient will come to you because of foot pain on the left or fasciitis on the left. Okay, and you're fixing fasciitis, but it doesn't go away because foot arch is decreased. You're trying to do those intrinsic muscle strengthening, but that doesn't go away, right? It's still staying there. So if you don't fix the pelvis, you won't be able to fix the foot. Okay, you won't be able to fix the foot. Okay, now you won't be able to treat symptoms, Washi. You won't be able to treat symptoms like, let's say you're giving some kind of massage and treatment for the fascia on the left foot, but that won't go away until you have arch. If the arch is flat, you will always have fasciitis there. We want the arch to come, medial arch. So the solution for this is, let's strengthen the gluteus medius. That's one of the solution. Okay, let's strengthen the right gluteus medius. But strengthening right gluteus medius takes time. It's not going to happen in like 1 week or 2 weeks. That strengthening will take time, like maybe 4 weeks. That's the normal duration for a muscle to get strong, 4 to 6 weeks. But till then, should he bear pain all the time? No. All right. So one of the major solution is, let's fix the pelvis. Let's align the pelvis. Okay. Now pelvis is dropped on one side, higher on the other side. Let's fix it. Okay. Let's fix it. So how do we fix that? What are the solutions? Gait training. What else? Okay, I'll repeat the last part. I meant he has weakness on the right side. So he's having pain on the left side, left foot. So how do we fix this problem? This problem happened because of weakness of the gluteus medius. The best way to fix is right by either strengthen gluteus medius on the right, but that's going to take time. So what we'll do is we have to go for some other solution. So we'll put a heel raise. We'll align the pelvis. We have to bring the pelvis back in the line. We have to bring pelvis back in the line so that that problem can be solved. Okay, problem can be solved because all this problem is happening because of what? One side is up, other side is low, right? So we have to fix it by bringing it in line. So how do we bring it in line? One of the solution is give a heel raise. Give a heel raise on one side. Okay, heel lift or heel raise on the one side. So on which side will you give a heel raise? Left or the right one? Left or the right one? Right one or left one? Right one is weak. Strengthen weak muscles and release tight muscles. Okay, that's going to take time, Saleh. Strengthening. Okay, so let's say, let me give a heel raise on the right side. Imagine I'm giving a heel raise on the right side. So what happens? This pelvis is already higher, and I gave a heel raise, so that went further up. It went further up, and this muscle went further stronger. So you made it worse. All right. So what we'll do is we'll give a heel raise on this side. That will cause this pelvis to go up. That pelvis goes up. So if this one goes up, this one automatically comes down. That goes up, this comes down, and they become even. You have to make sure how much height you need to give. Okay, you have to be careful with that because any hike on the left will cause a drop on the right. So that will make it even, and that's what we want. And that will fix the whole problem. You align the pelvis. You align the pelvis. So this pelvis went up. This went down. When this goes down, it stretches your right quadratus lumborum, and it shortens your left quadratus lumborum. Okay. So if right quadratus lumborum gets stretched, gluteus medius gets short, this will be stretched, so everything will be fixed. Everything will be fixed. The whole problem will be fixed. Okay. Just make sure the patient is active and moving around. The goal is eventually we have to take the heel off, that wedge off. Okay, we have to take that wedge out down the line, but that's a temporary solution. Okay, of aligning the pelvis. Down the line, what we want is make sure the right gluteus medius is strong enough to prevent any kind of drop. That's the plan. How much? It depends on how much drop has happened. Is right. Okay. Next thing is we have one of the solution, that is heel wedge. What about if this is a consequence of CVA? In CVA, which side you bend? CVA can be fixed to some extent with this. So in CVA also, you have the same kind of problem. Gluteus medius is weak in CVA too. Okay, so they will always have this mechanism, and they also bend on that one side. Okay, the side on which they are bending, that side will be higher pelvis. So you'll be giving wedge on the opposite side. On the opposite side. Okay. So in gluteus medius, in stroke, in which side do they bend? Right. Let's say they have stroke on the right side. Do they bend on the right side more? So in that situation, you'll give a wedge on the left. Okay. You'll give a wedge on the left side. Okay. So that can fix the problem to a significant extent. All right. That's how we fix it. But that was a good question. Okay. This is to some extent same as scoliosis, not the structural one. Non-structural scoliosis that happens because of muscle weakness. This is the same thing, same mechanism. So how do we fix that? Just by giving a heel raise on the drop side. Now you can fix it, right? Just by giving a heel raise on the drop side, you can align the pelvis. That will fix the non-structural scoliosis to a great extent. Okay, if it can be fixed through that. Now we do have to strengthen the muscle also. We do have to strengthen. How is it going so far, guys? Are you able to understand me? Are you able to connect? It's going good. Okay. Another thing that I want to discuss with you. Another very important aspect. In this situation, we'll have leg length discrepancy. Okay. This is the right. This is the left. And right pelvis has been high, has gone up. So which side will be longer? And on right side he's supinating, left side is pronating. Left will be longer. Okay. Left will be longer, right will be longer. Let's say what happens. How do we measure the leg length? From ASIS, we go from ASIS down to the malleolus, right? That's what we do. So after compensation, when you ask this patient to lie on a bed, then definitely left will look longer because it goes down and all. But when he's standing up, he has to compensate. Okay, he has to compensate. So what happens is right pelvis will be higher. So ASIS goes higher. In malleolus, now he'll be plantar flexing on the right. Plantar flexing on the right. So you can either measure to lateral malleolus or medial malleolus. Higher ASIS to the malleolus makes this leg longer. Okay, and again, supination is there. Supination is happening on the right side. So supination, that means increased arch of the foot. Increased arch and plantar flexed foot. That makes your right leg longer when he is compensated. Left side, you're measuring from ASIS to malleolus. He's having pronated foot. It was normally it's like this, but he's having pronated foot. So arch has gone. So when you measure from ASIS to the malleolus, length will be shorter. Okay, makes sense? Because the drop side, like increased arch that happens in supination, that happens in the right side, so that will be longer. On the left side, that will be shorter because of arch has gone. Because the arch has gone. Okay, I'll quickly repeat that, guys. These are important concepts, so make sure you understand. Okay, we measure leg length from iliac crest to the malleolus. Okay, after compensation, because this guy has to walk, his foot has to touch the ground. Okay, so when you measure from here to the malleolus, and this guy has already supinated the foot or plantar flexed. When you go from ASIS, which is already high, to the malleolus, that side will be longer. On the left side, the dropped pelvis. When the pelvis drops, your ASIS comes down, iliac crest comes down, so ASIS comes down, and from there to the malleolus. Malleolus also goes down because of decreased arch, right? Pronated foot is the short foot or short leg. Keep in mind, okay? If your foot arch goes away, that leg becomes shorter. If foot arch increases, that leg becomes longer. Okay? Very important. So now you know leg length discrepancy. which side is longer, which side is shorter. I'll take question with you. Let me finish all. Then I'll take question. Okay. So now you know a lot of things. And we are giving wedge on the drop side. Not because it's long or short, it's because we want to align the pelvis. We don't give wedge based on long or shorter. We just want to align the pelvis. So give it on that side that will bring the pelvis up. Okay. All right. So we have it clear so far. The muscles, the problems happening and different things. Okay. Now I can take the questions. Give me 1 minute. I'll take the questions. What's the question with you? We had a question. Or anybody else has any question or in thought process? Do we get in late GM weakness? That's right, physio. Heel lift will be on the left side. Heel lift will be on the drop side. Okay, the side that is dropped, not right or left. The side that is dropped. Keep it like that. Okay. Lateral or medial wedge, it's not like that. Medial or lateral, it's not like you don't have to fix inversion, eversion. You have to take the pelvis up. So it's like overall raise. Okay, overall raise of the foot, of the shoe. Dropped arch is a short leg physio. When the foot arch drops, that means flat foot, pronated foot. That's a short leg. Okay. All right, awesome. So we'll move on. Let me give you a question, guys. Let's see if you can handle that. Let's see if you can handle the question. Now, there will be involvement, Dipin. What do you want to know about that? There will be involvement of SI joint. For that, we'll have to go in the kinematics. Okay. If you want, we can discuss that in the end. We are still receiving some requests for invites. All right, guys, 10 more seconds. It's an easy question. Yeah, just hold on. Let others answer the question. All right, guys, 10 more seconds. Let's finish it off. Okay, done. Was it this hard? Yeah, you're not supposed to write answer in the chat box. You're just supposed to mark the poll and done. Okay, it wasn't this hard, but yeah, this was so basic, but let's work on it. Let's work on this. So this was the question. Patient with a Trendelenburg gait is being evaluated by PT. Patient has right shoulder higher than the left shoulder. Right shoulder higher than the left. Right shoulder is higher than the left. Okay, so I'm bending on the left side, right? I'm bending on the left side. So which side gluteus medius is weak if I'm bending on the left side? Left. Awesome. Left gluteus medius will be weak because my left quadratus lumborum is getting tight. That's why I'm bending on the left side. So first of all, you have to understand that when you have bending on the left side, left gluteus medius has gone weak. Okay. And right gluteus medius is tight. Okay. So in that situation, when you bend on the left side, what happens to the left pelvis? It comes up or down? It goes up. So left shoulder will be down, left pelvis will be up. Okay, that's what happens. Left shoulder is down. In this situation, you can see this was the opposite one. Right gluteus medius is weak. The right shoulder is low. Right pelvis is up. Okay, so whatever side is weak, gluteus medius is weak, that side you will bend. So in future, just remember it that way. If the right gluteus medius is weak, I'll bend on the right side. Left gluteus medius is weak, I'll bend on the left side. Why? Because that side quadratus lumborum will be tight. All right. Okay. And iliac crest also. So what is the diagnosis here and best intervention? So first of all, we know that he's bending on the left side, right? Because right shoulder is higher, so he's bending on the left side. So left gluteus medius is weak. So option A is gone. Right? So you have left, you're left with B and D. B and D. Gluteus medius weakness, strengthen by standing on the left leg and abduct the right leg. Okay. And D is strengthened by standing on the right leg and abduct the left leg. Because my left gluteus medius is weak. So let me show you. This is the image. Okay. Left gluteus medius is weak over here. All right. Let me change the color. Blue is the weak one. All right. In this situation, like many of you, how you should strengthen that muscle? How do you strengthen the gluteus medius? By abducting, right? By abducting the left leg. That's the function of gluteus medius. But there's a trick. There's a trick. Okay, hold on. So imagine like what most of you are saying is stand on the left leg and abduct the right leg. Right? That's what most of you are saying. So in this situation, let me write down one thing that you should know for your physical therapy career. The gluteus medius has two functions. Okay? It has two functions. One of them is abduction of leg, and second one is the pressure of pelvis. Those are the two functions of gluteus medius. Always remember that. How it depresses the pelvis? As I told you, it brings the pelvis down. Origin to insertion. Hold on. Origin to insertion. The line of pull. So when that gets short, that muscle gets short, it will bring the pelvis down. Okay. But there is a trick. Abduction of leg happens. That function, those fibers that are responsible for abduction of leg, they only work in the swing phase. Okay? And these fibers that are responsible for the depression of pelvis, they only work in the stance phase. Okay? In swing phase, depression of pelvis should not happen. Imagine you're trying to abduct your leg in swing. Okay? You're trying to abduct your leg and your pelvis drops. So you won't be able to clear the ground. It's harder. So always just practice. When you're trying to abduct, what happens? Your pelvis goes up and you abduct the leg. You don't abduct the leg with a dropped pelvis. All right. So when you're abducting, leg goes up. So imagine my left gluteus medius is weak. Okay. In this situation, I want to bring the left pelvis down. In this situation, because my left pelvis is up, I want to bring it down. Okay, that's what I want. I don't want to just strengthen the gluteus medius. The purpose is bring the pelvis down, and left side is the weak one here. So if I stand on the right leg and abduct the left leg, this is very important, guys. Pay attention. This is super important. Okay, standing on the right, abducting the left, what happens? Since this is the swing phase of the left leg, so depression property of gluteus medius will not work. Okay, so whenever you do abduction and swing, you further promote hip hiking. Okay, in swing you further promote hip hiking, and very important, when you're swinging the leg to the left, your center of gravity moves towards the left side. So your line of gravity moves towards the left side, and that is the reason that causes trunk bending on the left. Now imagine you're bending your trunk on the left, so gluteus medius, sorry, your quadratus lumborum further gets tight by bending on the left side, and your pelvis is going up. So basically, what are you doing? You're making the situation worse, right? You're making the situation worse by abducting this leg. Okay. All right. So giving you an idea, let's come to the abduction of the. Let's do abduction of the right leg. Okay. So I'm standing on this leg, on the left one, and I'm abducting the right one. Okay. Pay attention. Huh? Standing on the left one, abducting the right one. When I stand on the left one, depressor property of gluteus medius. Gluteus medius depressor property will work. That's what we want. And when you're abducting the right one, your line of gravity comes on the right, so your trunk will bend on the right. So when your trunk bends on the right, you're basically stretching the tight quadratus lumborum, and you're shortening the weak quadratus lumborum, right? So that's what we want. That will bring the pelvis down. When you stretch the left quadratus lumborum, that will bring the pelvis down on the left side, because gluteus medius is working as a depressor on the left side in this situation. So always you want to strengthen the gluteus medius, especially for the Trendelenburg. Make sure you stand on the weak side. Make sure you stand on the weak side and abduct the good leg. That will improve the depressor property of gluteus medius, and that will bring the pelvis down, and that will fix the problem. Okay, did you get it? Was it too hard to understand? Yeah, it is tricky. That's what they do in the exam. It is tricky. Sometimes it's hard to take in all the information. Like, how many of you thought that gluteus medius depressor property is like such a big function? We never pay attention. If somebody asks you what is the function of gluteus medius, what do you say? Abduction. But that's not going to fix your Trendelenburg problem. Okay, that's not going to fix the Trendelenburg. Yeah, we'll again explain you in the end, but we are kind of short of time, so we have to move on. So don't worry, you can call me later on. I'll explain you the whole thing. Okay, but remember this mechanism. Okay, all right. So going back to the question, so you have to stand on the weak side, and weak side is the left gluteus medius, and abduct the right one. So, okay, that's how you do in the standing. Okay, now in supine position, can we strengthen the gluteus medius in supine? In supine, it's fine. I mean, it's fine if the person doesn't have enough strength to stand up and all. In that situation, you can do open chain. Normally, we always prefer closed chain, like standing on the weak leg, abducting the right leg. So closed chain is the best option. But if somebody is like super weak, stroke patients who have poor balance, in that situation, you can make them lie supine and abduct their the weak gluteus medius. That way, to some extent, it can help. To some extent, open chain in the bed can help. But if you have the option of closed chain, do the closed chain. Okay. All right. So we did heel raise on the drop side. Always keep in mind, closed chain, gluteus medius strengthening. Open chain should be avoided as much as possible. Not contraindicated completely, but it should be avoided because you're going to further shorten that muscle. Yeah, further shorten that muscle. We can do open chain in supine position because in supine position there is no role of gravity actually. I mean, gravity is not, you don't have to fix your trunk. Okay, but when you stand up, your trunk position is very important. But when you're supine, it's all relaxed. It's not working. Okay, you don't have to balance the trunk in supine. In that situation, you can do open chain, but not in standing. Never do that in standing. Now, how many of you have done it this way? How many of you have treated a patient with Trendelenburg? So to be close kinematic chain is same as standing on the weak leg. That's close kinematic for the left gluteus medius and abducting the right leg. Okay, when you stand on the left leg and abduct the right leg, that's a close kinematic chain for the left gluteus medius. That's right, Laura. The right option is the right answer is option B. That's the right answer. Okay. All right. Now, you know what? The idea is not just to tell you about how we guys teach. Since you're like spending time with us, you guys should learn something. Okay? You guys should take something home. Like this is an important mechanism. Like how we started with gluteus medius weakness, that leads to bending on the right side. Okay, and then all the problems in the leg, left and right. Okay, all the problems left and right. And it's not only when you know what, when you think about passing this exam, that's when you defeat yourself. You should think about becoming a good physical therapist. Okay, like the goal should not be just to pass the exam. Okay, let me pass the exam. You can never pass the exam if you just keep studying those books. You have to go out of the books. If you keep studying Maggie, Kistner, Norkins, you'll become the puppets of those books. You can never think out of the box. So you have to go beyond. Now, this thing you're not going to find in any book, like how overall mechanism happens and how that leads to trochanteric bursitis or fasciitis. Okay, so that's why you have to think out of the box to develop that thing and take something home from this class. Okay, all right. Now again, we have various other things. There are like latissimus dorsi and gluteus medius, gluteus maximus. Even they work in cross. So right, and the left one. Right gluteus maximus tightness, that will cause tightness on the left latissimus dorsi. Can you think? Can you think about that? How right gluteus maximus tightness leads to tightness of the left latissimus dorsi. Okay, now let me just give you some brief idea. When my right origin insertion, that's right, Israel. When my right gluteus maximus gets tight, that pulls the pelvis down, left pelvis goes up, your latissimus dorsi originates from there, goes up. So basically distance between origin and insertion decreases. So left latissimus dorsi gets tight. If left latissimus dorsi gets tight, you can understand that what is the function of latissimus dorsi? Internally rotation of the arm, right? Internal rotation of shoulder. That will cause adduction, your pectoral tightness. That will cause various other problems. Yeah, that's how you learn. When you start connecting your pelvis with the shoulder problem, that's how you learn. So do that. When you guys are like studying, that develop that thinking. Now, the reason I'm discussing these things with you, why you should develop your thinking, because I'm trained by FSBPT how to make questions. So when we make questions, we just don't like ask you the problems in the hip because of gluteus maximus. We will connect it with the shoulder. And that time you should be able to understand what's going on. Okay, because we are going to make those kind of questions. Okay. All right, so make sure you start preparing like that. Okay, start preparing like that. That's the idea. If you just start going to read the books, I have a lot of students like who have said that I have finished all the books, but I never passed. Like 4 attempts, 5 attempts, we are not able to pass the exam because you're not thinking out of the books. Okay, right? We don't have anything right now, Israel, for the shoulder because we just wanted to keep the class short. But definitely, if you want any questions, you can contact us and we'll give you. So go home, think about this, your obliques and adductors, think about different options. So this is it from my end. I'll pass it on to Pooja, who has got something. Give me 1 minute. Yeah, leg length discrepancy. So I'll just keep it over there. Now I'll pass it on to Pooja. Okay, and she will discuss with you guys like some kind of questions, how you should work on the question and how the concepts are developed. Okay. I'll be I think Pooja will be going on for some time and then I'll discuss what we offer in this class. Okay, what kind of things we offer in the class. Okay. All right. So Pooja, are you there?
Yes, Ankit. Hey friends, how are you all doing today? Good? Wonderful, friends. I'm Pooja. I'll be teaching other systems, and I passed out NPTE 2 years ago. I was a student myself with Ankit, and he's the person behind my passing the exam. So I owe a big thing for NPTE study buddy. Yes, friends. So I was in 2016, I passed out, and I'm practicing as a home health physical therapist. Yes, he's too good. All the concepts he teaches is crystal clear. Thank you, Pooja. So, as you all know, I'll be teaching other systems with Study Buddy team. So, what do you all think you see in other systems? Burns, lot of stuffs. Yes. So, as you all know, other systems includes integumentary, metabolic and endocrine, gastrointestinal, genitourinary, even lymphedema, you're right, and system interactions. Too much to remember, Maria. I agree with you for that. So out of all this, do you all think system interactions is the one which catches you all the time? Why do you think so, friends? Have you all thought about it? Safety, yes, Israel, that's right. I can take that. Sometimes we get confused by connecting different systems, isn't it, friends? So you read a practice question, you're stuck with one concept. We are not able to connect it with different relationships, isn't it, friends? So that is the biggest problem we all face when it comes to system interactions. Okay, so what we usually do to help with system interactions is try to know what is the main problem the patient is facing and what are the different types of interactions the patient can have. Okay, for example, a patient who's having diabetes mellitus, he can be having n number of problems, right from the eyes, right from the joints, right from feeling fatigued, right? So can you all connect it that way, friends? They feel very fatigued with activity, right? Is that true? So for that, we need to try to connect different systems to make a definite conclusion there. Okay, so we go wrong always connecting the dots. So today I have about 3 practice questions with me, and I want you all to read the practice question for about 50 to 55 seconds. Take time and please do not answer in the chat box until I tell you. Okay, friends, so are you all ready for that? And first and the foremost, I'll be posting the picture. I want you all to look at the picture first. Okay? Do not answer anything on the chat box. Okay? Let's go for it, Pooja. No answering. Okay? Just look at the picture you see here. Okay? Focus on it. I'll give you 20 more seconds to focus on the picture. Did you all see the picture, friends? There is something going on here. Okay? Remember this picture for the next practice question I'm going to post here. Okay? Are you all ready for that? Okay. Do not answer in the chat box, friends. Okay? Twenty more seconds, friends. Go ahead, friends. Answer this. So we stuck between option B and option D here, right? Okay. Shruti, kindly refresh the page. Okay. So would you all agree with me if I say there were two different systems getting connected here? And which are those? Can you tell me what is all getting connected here, friends? Integumentary and CV, cardiovascular, right? So let me go back to the picture which I just put up. Okay, I'll come back to the question. I'll explain you what it is. Surbi says endocrine and vascular. That is more specific. I'll take that, Surbi. That's very good. So what is that we see here, friends? Do you all call it an ulcer? Okay. So Laura says it is stage 4 ulcer. Do you think it's stageable, Laura? When you have so much of a scar or black tissue there, do you think we can stage it? It's an unstageable ulcer. Okay. So if I say, or go ahead, name the ulcer we see on the picture there, rather. Neuropathic ulcer. Kamakshi, this is not arterial ulcer. This is a neuropathic ulcer. Okay. Because of the location, I call this as an neuropathic or diabetic foot ulcer. Okay, folks, because usually ulcer of this kind happens in the plantar surface. Yes, physio, they both are same. Okay, so they both are same. Diabetic and neuropathic, both are same. So it is happening in the plantar surface of the foot. Okay. Arterial ulcer location is different. Okay. So arterial is mostly lateral. Is it Shajya? Everybody agree with her? It's because of the location of the major arteries, arterial ulcers happen on the lateral surface, and that is right. Okay. So you all agreed with me it was a diabetic foot ulcer, right? That's good. Now, let me read this question. Okay. A male patient with this type of ulcer has a long history of cramping in fingers, with fingers turning white and blue. Okay. What do you think is happening to this diabetic patient here? You saw the ulcer, we got to know it was diabetic. Why there is a cramping in fingers? Mercury says it's kind of cyanosis, vascular issue. Do we have a name for it? Kelsey says it's Raynaud's. How many of you agree with me and Kelsey for that? Right? So what is Raynaud's phenomenon, friends? What happens usually in Raynaud's? There is vasospasm of arteries, right? It can be in the fingers. Digital arteries, yes, I can take that. So there will be less perfusion, isn't it, Kelsey? Less oxygen, less perfusion, okay? So mostly they say you need to avoid cold. Cold weather can be one of the reasons for Raynaud's phenomenon, isn't it? So keeping yourself warm can be one of the way to deal with this type of disorder, okay? So now, this patient, he's got a diabetic foot ulcer and he's got Raynaud's disorder. Okay, those two things we all could connect. That's wonderful. He is on corticosteroids for a long time to decrease the symptoms of cramping. Okay, so usually you think all the patients with Raynaud's, they are on steroids to decrease the inflammation. Isn't it, friends? That is true. Okay. What effect the leg ulcer would have with corticosteroids? So patient is on steroids. He's got an ulcer. Do you think it's a good combination there? I don't think so either. Okay. Let's work with the options now. Option A, ulcers will heal faster than normal. Do you all agree with me for that? There will be more complication because of steroids, right? Steroids, it's an anti-inflammatory. It decreases the inflammation, but it has got a negative effect on wound healing. So what is the negative effect we see with steroids? Can anybody answer that for me, friends? It causes impaired healing or delayed healing. Okay, so say for example, whatever is the tissue growth factor, okay, which is needed, and including the collagen deposition, which is needed for wound healing, comes very delayed because of steroids. Okay, that is the basic negative mechanism of the steroid. Okay, are we clear with the mechanism of steroid till now, friends? Okay, that is good. So, delayed wound healing. How many of you think it is option B? So, most of you think it causes delayed wound healing. So, are you all not going to read the option C and D before telling it is option B? Or are you all going to read option C and D before confirming the answer? Let's read it. Isn't it, friends? Because to come to the conclusion of the right answer, you have to read option C and D. Okay? Make it a practice of reading all four options before you choose the correct ones. Okay? Increase in blood glucose levels helps in wound healing. How many of you think blood glucose level which increases in the body helps in wound healing? It's completely negative and false, isn't it? So the first and the foremost, if a patient has got a diabetic ulcer, they would ask the patient to decrease the blood sugar levels, isn't it, friends? So it is going to have a negative effect on wound healing. Again, just like steroids, it's a false statement. Okay, let's say it's not the right one now because we read it. Steroids have an agonist action against tissue growth factor and collagen deposition. Is everybody having a problem with audio, friends? Lakshmi, I think it's at your end, my dear. Okay, can you please check your connection? So steroids have a agonist action against tissue growth factor and collagen deposition. Is this statement right? Most of you chose option D there. It's got an antagonistic action, isn't it, friends? Because as I just explained you, steroids hamper the collagen deposition, and this statement is completely opposite. Okay, it is not an agonist, rather it is an antagonist. Okay, so now I can confidently say the effect of wound leg ulcer with steroids is delayed wound healing. B is the right answer. Sometimes, friends, even though you do not know the concept of steroids, by doing something called process of elimination, okay, Laura, the correct answer is option B. Okay, so you're putting a smiley there. Sorry, I thought it was D there. So option B is the right answer there. But it says against action. Can you explain what is it, Vidhi? Agonistic action. Agonist means it kind of helps with wound healing by bringing in the tissue growth factor and collagen within. Okay, it is not an agonist. Rather, it is an antagonist. Okay, antagonist because it is not getting the collagen deposition happening there. Okay, are you all clear with this concept, friends? Did you all understand how we try to connect a diabetic foot ulcer with Raynaud's and the treatment of corticosteroids? So this is the base of system interactions, friends. So once you try to connect different systems, there is no way we can go wrong with this. Okay, so let's see in our next practice question here. Please do not type in the answer, friends, until I tell you. Please give everybody about a minute before you start typing. Okay, thank you. Yes, if everybody's ready, you can answer, Pooja. Go ahead, friends. Okay, is somebody still working on it, friends? I think most of you typed it. Okay, let me read the question for you all. I'm going to ask you many questions related to this because I hardly see any right answers there. Okay. A female 77-year-old had a fall and now represents with shorter leg on the right side, with right leg, shorter leg on the right side and right leg outwardly turned. She has severe difficulty in transverse and is mostly bedbound. Okay. Upon therapist arrival, she is short of breath with inability to recognize the therapist. With vital signs of 98 temperature, respiratory rate of 26, oxygen saturation of 87, therapist deems it as an emergency issue by calling EMS. What disease is the patient representing with? Okay, this question has two symptoms again here, friends. If I say that, would you all agree with me for that? The first half of the question until here represents something and the second half is representing something else. Okay, let me read the first part again. A female 77-year-old had a fall and now represents with shorter leg on right side with right leg outwardly turned. She has severe difficulty in transverse and is mostly bedbound. How many of you say it is a fracture? Is it a fracture, friends? What type of a fracture is this, Maria? And even Shazia. Ashwini and Pooja says it's not a fracture. Femoral head fracture, right? Do you all agree with me if I say that? It's okay, Pooja, we are all learning. Don't worry about it. Possible fracture, Halid, right? Neck of the femur can be fractured here because shorter leg on the right side and right leg is outwardly turned. What does this outwardly turned mean? Is it an external rotated position or an internal rotated position there? It's okay, Ashwini. I'll clarify your confusion there. Don't worry. So you all agree if I say it's externally rotated there, right? So there is a fracture happening here, friends. It's happened. How many of you say, what type of a dislocation is this? Is it an anterior one or a posterior one? Posterior causes shortening. How many of you agree with that? Right? So this is a posterior dislocation of the hip happening here. Physio, you were asking me, she has a fracture. Why is she bedbound? She has severe difficulty in transverse and is mostly bedbound. She had a fracture. That is the reason she's got difficulty in transverse and she's bedbound because of the fracture there, physio. Okay, so it is not directly told it is a fracture there. That is because there are two things I want you to connect with this statement here. Female, 77-year-old. What are they usually prone for? Osteoporosis, falls, and fracture. Would you all agree with me for that? Okay, it is trying to connect osteoporosis with a 77-year-old female who's had a fall and is bedbound because of the fracture. Okay, did you all think in these terms when we spoke about it, friends? This is what is system interactions, okay? We have to connect it. There is a female. Unless and until they want you to think in terms of the age, they will not specify the age for that. Okay? Age is what is very relevant for osteoporosis, and females are more prone for hip fractures. Okay. Upon therapist arrival, she is short of breath with inability to recognize the therapist. So she's having shortness of breath. She's having some confusion. If I call it a confusion, would you all agree with me for that, friends? She's not able to recognize the therapist there. She's confused. Okay, her vital signs. Temperature is 98. Do you call it a temperature? Does she have a fever here, friends? There is no fever. Okay, respiratory rate is 26. Is the respiratory rate increased? What is the normal respiratory rate? It's 12 to 22. Wonderful. Know the numbers. It is really important. Okay. Respiratory rate is high for sure here. Oxygen saturation is 87. Is 87 the below level of oxygen saturation? There is some pathology here, right? So when the patient is at rest, what is the oxygen saturation? What is the minimum oxygen saturation which is needed at rest? Anything above 88. Is that true, friends? If I say anything about 88 is good, would you all agree with me for that? Okay, so with activity, we never want the oxygen saturation to go below 88. Remember that. Okay, anything above 90 is what is considered to be good. Okay, know the numbers. That completely changes the answer. So you got to know she's having shortness of breath, oxygen saturation is decreased, and her respiratory rate is high. Therapist deals it as an emergency. What is the disease the patient is representing with? Okay. Option A, stroke affecting middle cerebral artery. How many of you think it is middle cerebral artery here? Can you justify your answer? Why you all think it is not middle cerebral artery? Because middle cerebral artery affects upper extremity more than the lower extremity. If it was anterior cerebral artery, would you all think about it a little then, right? It is impossible for middle cerebral artery. That's okay, Ashwini, no problem. So whenever there is middle cerebral artery affected, the symptoms would be more in the upper extremity. For anterior cerebral artery, it will be more in the lower extremity. That being said, completely out. Okay. Now, option B says, X-ray showing lobar consolidation. What do you think it is, friends? It is not telling you exactly what it is. What do you think it is? Sandhya, wonderful. High five to you, Sandhya. It is pneumonia. Okay, it is pneumonia. So what is happening here is pneumonia. Okay, let's keep that option B. Again, would you all not read option C and D here? Or do you want me to read it? Let's read it. Okay, geriatric depression scale of 4. Though you do not know what is GDS of 4, how would you rule out this option here, friends? Do you see any depression symptoms with this patient? Only one thing is, she's bedbound, but she's not depressed. She's bedbound because of physical inability here. She's not depressed. Symptoms which are not shown in the question, never ever try to connect them. Okay? It's completely wrong. And geriatric depression above 5 is pathological. It's just a distractor. Wonderful con. That is what I call it. We have a lot of distractors all the time for us not to come to a right conclusion. Rule that out. Okay? Pyelonephritis. What is pyelonephritis, friends? Upper urinary tract infection. Is that what is called as pyelonephritis, friends? Upper UTI. Okay? Whenever the kidneys and the ureter get infected, We call it pyelonephritis. Do you see any symptom of UTI here? Any burning micturition? Any excessive voiding? I don't think so, right? It is not the right answer there. No. X-ray showing lobar consolidation. Okay, this is what is called as pneumonia here. I'll tell you what has actually happened. Can anybody tell me the temperature here with this patient was normal? Isn't it, friends? Why is this patient showing signs and symptoms of pneumonia even though there was no temperature problem here? Why is that? Bedbound. Usually, when you cross above 70 years, they do not spike a temperature, okay? Because hypothalamus is not communicating with the body temperature, okay? Once we cross the age of 70, they usually do not have high temperature unless they have septicemia. Remember that, friends, okay? You can all tell me the temperature is normal, but still why is it pneumonia? That is because elderly patients, they always show signs and symptoms of confusion. Okay, whenever they have pneumonia, they do not spike temperature. Ashwini, I'm going to connect it. They do not spike temperature. Rather, you see that respiratory rate is increased, oxygen saturation is decreased here. Okay, Ashwini, the main connection here is, yes, Shazia, I'll tell you what it is. This patient is bedbound. Okay, this patient is bedbound because she's had a fracture. Did you all understand till there, friends? And when the therapist is entering the patient's room, the patient is short of breath. She is not able to recognize a therapist. So signs and symptoms of confusion there with normal temperature and respiratory rate and oxygen saturation is messed up because of infection in the lungs. And mostly infection in the lungs is because of immobility there. Okay, pneumonia happens when the patient especially does not sit upright or start walking. Okay, bedbound leads to infections in the lungs. So what we see is, yes, Halil, you're right. X-ray showing lobar consolidation. Whenever there is consolidations on the X-rays, it says the lungs are infected. This is what usually happens in a bedbound elderly patient. Okay, did you all understand now? Whoever said it was confusing, this is the, yes, lobar consolidation is what you see on X-ray, and that usually happens with pneumonia there. Yes, physio. You do not see temperature spikes in elderly patients, okay, because of hypothalamus not communicating well. When there is pneumonia in young patients, like small children, they have temperature above 103. Okay, whereas in elderly patients, like this 77-year-old female, she's not going to show any temperature changes. Kids of this age, at small age, would show temperature, but not elderly patients because of hypothalamus. Okay, physio. So how did you rule out D? Pyelonephritis was upper UTI. Okay, I do not see any symptoms of upper UTI infection here. Okay, it could be positive Murphy's percussion test, which you do on the posterior lumbar region. That could be painful with upper UTIs. Okay, and moreover, oxygen saturation will not be so low if it is an upper UTI. Yes, Vidhi. That is the reason most elderly patients, they go or land up in bacteremia or septicemia because we do not see any changes with temperature. Okay, keep this concepts in mind. Okay, did you all understand, friends? You want me to explain it again or are we good with it? Jenna, did you get it now? But you answered it right. That's wonderful, friends. That's really good. Ankit, I have another question.
Okay, I thought you only have two.
Okay, this is the last one, folks. Okay, do not answer it until I tell you, please. Go ahead, friends, answer it. Okay, friends, awesome. Then I've got no idea about it. Okay, so let me read the question for you all, friends. Okay, a male patient underwent right TKR 2 days ago. A home health physical therapist is referred to help recoup from TKR. Patient voices he just had a fall and fell on right pelvis. Upon physical therapist assessment, client represents with pain posterior until right knees, which is radiating in nature. Okay, he's got pain until the right knees, which is radiating. When the therapist palpates the symphysis, he feels the patient's bladder. Okay, he's fallen on the right and he's had a fall on the right pelvis. Okay, the patient, you can make out the symphysis pubis, you can palpate the bladder there. Upon talking further, patient verbalizes he has had nocturia, blood in the urine, but he forgot to tell his physician as he was busy with his TKR pre-operation sessions. Okay, what could the patient possibly be suffering from? What is the connection of TKR with prostate or with pancreatic carcinoma? What do you think is happening here, friends? Do you think this patient here is kind of neglecting all the symptoms he's been having because he's focusing so much on his TKR operation here, right? Bladder weakness, Ashwini. Okay, you call it weakness there. Okay, so he's got pain which is posterior until right knees and which is radiating in nature. Okay, whenever the therapist is palpating the symphysis pubis, he feels the bladder. Okay, can anybody tell me in male what is the relationship of prostate with bladder? What is the anatomical orientation of prostate with bladder? Yes, Laura. Prostate is above the bladder. Khalid? How many of you think it is above the bladder? Prostate is underneath the bladder. Okay, let me show you a picture. Okay, this picture is just for knowing. No problem, Khalid, no problem. Okay, this is the prostate gland. This is the urethra here. Okay, the bladder is underneath here. Okay, did you all see that? So whenever there is prostate gland enlargement, this goes big. Do you think there will be some pressure on the bladder here, friends? Can it cause some overactive bladder, like frequent maturation there? Right? That can happen. Okay. So that being said, there is some, he also says there is nocturia. What is nocturia? Frequent urination at night. So symptoms of overactive bladder, right? And there is some blood in the urine also. Okay. So how do we come to correct conclusion here is spinal cord compression. So if this patient had a spinal cord compression because of the fall, do you think we could have the symptoms here, friends? Shazia, it is possible. Why do I say that? Is because he's having some radiating pain there. When there is radiating pain, can the bladder also get constricted there? How do we rule out now? There will be some dermatome which is affected if it is a spinal cord injury. Isn't it, friends? Or probably we would see some deep tendon reflexes which can get hyper exaggerated. And blood in the urine, do you think can happen with spinal cord injury there? I don't think so, right? That is the way you can rule out spinal cord injury there. Okay, let's rule it out. Good job, friends. Liver carcinoma. How many of you think it is liver carcinoma? Do I see any symptoms of liver-related pathologies here? And if at all it was liver-related pathology, where would the pain show now? Is it on the right shoulders or the left shoulders? Right shoulders. I don't see any problems with right shoulders. No. Rule it out. Okay. Pancreatic carcinoma. How many of you think it could be pancreatic carcinoma? No, it is not possible. If at all it was pancreatic carcinoma, would it have some signs and symptoms of icterus or jaundice-like symptoms? Yes, it would. I don't see any icterus happening here, right? Completely no. Since it is a male patient, prostate carcinoma can happen, okay, because of the anatomical orientation with the bladder. Okay, did you all get this, friends? Most of you got it right. Good job to you all. Okay, was it interesting? Did you all like it, friends? This is the way you have to try to connect system interactions. Okay, thank you all so much for your time. Good luck to you all, friends. Thank you. Ankit, I'm passing over to you.
Guys. Yeah, it was nice learning other systems. And you know what? System interaction in the new pattern, it has got like 10 questions. And normally what I found is like, because I see student scores all the time, they perform bad in system interaction. Okay. So for system interaction, you have to be like very good in connecting different systems. And that's the area where we are normally bad. Okay. So make sure you guys get like in depth. That's very important. All right. So that's it for today. Now we are starting the new class from tomorrow and a new batch from tomorrow. And that will be in the evening, 8 p.m. So what do we do? Like the class fee is $799. It's a little expensive. There are a lot of other classes out there for $500. why are we still charging $800? Like, why are we not keeping it 500? Because the reason is we offer you like 70 lectures. We offer like, especially for the internationals, our basics are not that great. We are not able to connect different things. Like how I was teaching you musculoskeletal, those things you have to develop. Okay. And when you just read it by yourself, I've seen that normally people struggles. Normally people struggle with that. Okay. So that is the reason you have to develop that thinking. And we do that in the class. That's what we do in the class. That's right, Israel. It's $799. Yes. Things are expensive also. And quality never comes cheap. Okay. So 70 classes and goes on, and each lecture will be like this. So basically, this goes on for 3 months. 3 months. And every day 6 to 7, like 7 or 8 p.m. Like I teach at 8 p.m. That will be 2-hour class, which you can attend and develop your thinking, and it goes on. And then after 3 months, we'll give you a practice exam schedule. We'll give you a practice exam schedule. So you take another those practice exams, and you'll have to submit us the scores, and we'll tell you where are you lacking. Okay. Now all these classes, like what we are teaching right now, that's a live class, and it also gets recorded. So you get a chance to watch it again later on if you missed it due to some reasons. If you missed it due to some reasons, record it. And especially for the internationals with a lot of problems in developing your thinking, what we recommend you to do is like go there and talk to our students who pass the exam. What do they think? And normally, you know what you'll find, that they joined those other classes and then they came to us. They joined those classes, then they came to us, and then they improved. Okay, you can go for a cheaper option, but when you take exam again and again, you're investing a lot of money, a lot of time. Time is money, guys. When you're taking exam again and again, it's like, and if you fail multiple times, that's a lot of depression. And see how much you're sacrificing, like your kid, your other things, your job, and you're sacrificing too much. So it's always a good idea to spend money before and go there in a well prepared manner so that you can finish it off right away in one attempt. Okay, taking it multiple times, you're spending too much money. So you have to make that decision. Talk to the other students what they found was good in our class and what they found that did not help them in other class. And we are also trained by FSBPT. I'm trained by FSBPT on how to make questions. So we'll be following that pattern. And definitely, yeah, we have the installment option. Okay, we have the installment option when you can pay money in installments. You don't have to pay $800 right away. You can pay in installments. Okay, and it's a one-time fees. Okay, like suppose your evaluation is in process, you can join us. You can watch, like the classes are starting from tomorrow, May 5th. It will go on till July 15th, one batch. And then again, the next batch will start from August, another 3 months. You can attend that one too until you pass. In case due to some unfortunate circumstances you missed or failed the exam by a few points, don't worry, we are not going to leave you or ask you to go. You can again attend the classes. So it's a one-time fees. Attend the class until you pass. Okay. We in $799 we give you everything. Okay. You'll get strategy classes. You'll get 1,000 questions of Saunders from us. You'll get one more exam from us, and strategy classes. Strategy classes are very important. You know what? What I've found, students normally lack in, especially internationals, they lack with multiple choice questions. Okay, multiple choice questions, they don't know how to eliminate options. So you have to have a proper strategies to answer those multiple choice questions. I have seen a lot of students who studied all the books still kept failing because they lacked strategies. They lacked strategies. You have to develop those strategies, like what are the keywords, how to anticipate, how to eliminate the options. We'll have those classes. Okay, we will have those classes. Now for the strategy classes, like especially those students who have taken the exam in the past, if you scored above 590 or more, you have the option to just pick or just select the strategy classes. Okay, if you have scored that much. So above 590, you have to just pick the option of selecting strategy classes. You can enroll just for the strategy classes and we'll train you, because I think at 590 you don't need much studying of different topics, but working on your exam taking skills will help you improve your score or pass that range. So we have that option, and that's like $199. And that you get like 6 classes, 6 to 8 classes, and then phone calls and Skype sessions, and that's all we can have. Other students who scored below, you guys should, I recommend you to join the whole batch, the whole package of $799, because it gives you access for multiple batches. Okay, that is the reason we are recommending you that. But again, even if you don't join the class, it's completely fine. We can be friends. You can be in touch with me, ask questions, discuss things, and if you have any problem, like, let us know. Okay, we are happy to help. Laura, will have to be a little quick for July. If you join, you will have to be a little quick for July. Okay. Strategy classes are included in $799, Rejani. In $799 you get everything. In $200 you only get the strategy classes. Now you know what I see out there, like it's kind of a business. This class is not just like take your money, and that is the reason we give you access until you pass the exam. I see out there a lot of people are giving you, like, are charging you for the schedule. They'll make your timetable. You're not that dumb. You can make your own schedule and we can help you. No problem with that. If any of you who doesn't join the class, ask for help, we'll help you. Okay. So the purpose is not just to make money, it's help you. I know sometimes it can be expensive, but ask those people who took the classes, did they find it expensive after attending those like few batches? Ask them, what do they think? Okay. And if you ask me, I'll tell all the good things. So it's always a good option to talk to your friends out there on Facebook. They can tell you the right thing. Okay. Jana, you know what? That's the benefit of a class. Like, you know what happened when you guys studied Trendelenburg? It will take many days for you to develop that kind of connection. What we taught to you in like 1 hour, 2 hour, it will take, like, you'll have to study from here and there and then think. It takes time. And that is the benefit of this class, that we tell you how to connect and we save your time. We give you some direction that, okay, study like this. This is what you have to study. So that's the benefit of attending a class. That's what you're going to get, Jenna. Okay. The next batch will start in August. For PC, Sandhya, the cost is $599, because in PC, you guys don't have to study about ECG. You don't have to study about pharmacology. You don't study about research. You don't study about spinal mobilization, cranial nerve. So a lot of things that you don't study that brings down the cost. So that's $599, and you'll have less lectures for PC. Physio, you can definitely register now. It's good enough for July, but you'll have to be quick. Marcelo, the program goes on for like 3 months of teaching, and then if you are not going for July, you can start the practice exams after 3 months. If you are going for July, we'll give you the practice exam schedule in these 3 months along with the classes access. Okay? The schedule for classes are like, we'll teach you in the evening. Like, I'll be taking classes in the evening at 8 p.m., 8 to 10. Okay, and then other tutors will be teaching at 6:30, 7 p.m. in the evening, EST, New York time. Yes. Kelsey, that's for the strategy classes, $200. That's specifically for those people who scored high last time, like 590 or more, because those people who scored like 560, 570, they still need to develop that conceptual understanding. And what I found is people are in that range, 550, 560 or below that, they need to go through the lectures to develop that thing. For those who are 590 or more, I won't recommend you to spend $800. With strategies, you can still cover the you can still clear the passing rate score. Going for January exam, Rajani, you know what? Earlier you join, it's better, because when you're going for January, You'll be able to attend the classes from May to July, first batch, from August to October, second batch, and then from November you can practice the exam. So that gives you access to class twice to attend and develop your thinking. Yes, the exam of New York is same as all over states. It's the same exam, Nina. Sandhya will provide you the schedule and everything once you join the classes. And you guys can also visit our website, nptestudybuddy.com. Again, let me write it down for you guys. So that will give you what we offer. So over there you can read about us, like how we do and all, and we can go from there. Basic concepts, Nidhi, you should start studying about muscles. Origin, insertion, nerve supply, action, that's very important. Okay, you should be very good with that. And think out of the box. Studying alone won't help, guys. Studying alone won't help. You'll have to develop your thinking, thought process to pass this exam. This exam is not something that you can just clear by reading the books. It's different. Because as I told you earlier, the way they make questions, the way they asked us or they trained us to make questions, that's a higher level than what you have in the books. So you have to connect different systems to answer those questions. Ishan, you can still do that. You can still enroll for the class. No, we teach 7 days a week, Eula, and I'll teach some days. Some other tutors will teach some other days. So it's like that. Well, Chintan, I'll recommend you can talk to me, but I'll recommend you. Normally, we lack a lot of concepts, so you can talk to me, but I'll recommend joining the whole class, whole package. Thank you, Pooja. PC and NPT both are starting from tomorrow. Okay, tomorrow will be an introductory class. How many hours? The classes will be 2 hours long. Each class will be 2 to 2.5 hours long. Okay. Not really, Nidhi. You know what? The lectures, like what you're going to learn in these 3 months, that will be a lot. Okay. If you try to study that much in these 3 months, you'll have to like study for 7-8 months to reach that 3 months, what we are going to do in 3 months. Okay. So that is the reason in 3 months, if you want to quickly finish a lot of topics, a lot of concepts in short duration, that's why we recommend you to join the class. A lot of people are never able to develop some of the concepts like Trendelenburg, like connecting your shoulder with your pelvis with the foot, because this problem wasn't at the pelvis, right? And it can give you shoulder problems because of latissimus dorsi, and it can give you foot problem. So that connection, if you are able to do that, awesome. If you're not able to do that, that's what we do in the class. We develop your thinking, because NPTE exam is not something like you have a key and you can pass any day. You'll have to reach that level to pass this exam. And keep in mind, if you're super smart, you'll be able to make it any day. But if you're an average student, you'll need that kind of help. You'll need that help, okay? So think about where you stand, what's your level, understanding and all. Or talk to me also, where do you stand? I can ask you a few questions to check your understanding level and we can go from there. Yes, and what we offer more is like we have WhatsApp group. There are 2 WhatsApp group. You can use one of the group, like it has like a lot of students who will discuss the doubts, concepts, what we study in class. And that's one of the benefit of being part of the class, because it gives you access to like all the students who are sincerely preparing for the exam. Okay, who are sincerely preparing for the exam. So that can be very helpful. Okay? That can be very, very helpful. Yeah, you can send me a message through email. My email ID is, I'll just write it down here. And if you have any inquiry about the class, you can email at All right. If you want to talk to me, my number is that area code 662? 662, that's from Mississippi. That's where I studied. You know what? When I came to States for the first time, and how like I came to States like 7, 8 years back. So how you are like when you what's the imagination? What's the picture you have for America in mind? Like think of Las Vegas, Miami, good all the good places, New York. But then I landed in Mississippi, and Mississippi is different. All right, Mississippi is not the one that you see in the movies. Okay, it's different, but they don't show us. I'm like, you guys never showed us these things. That's a trap. That's a trap. Okay, so this is my number. Feel free to contact me, call me. Maria, the class will be almost every day. Timing will be 8 p.m. You guys will get the schedule that will in advance tell you the timings. Some of the timings will be at 6:30. Yeah. Some of the classes. Sooner the better. Yeah. And especially this is a one-time fees, which gives you access until you pass. So you can keep attending. And I've seen that those students who attend classes multiple times, they tend to perform better than others. Okay. All right. All right, guys. Thanks for your time. I won't say, Hiloni, you don't have to clear your basics because, Hiloni, what will happen is if you start studying about basics, you will take a lot of time to understand that, and then you'll start the actual thing. But if you directly come in the class, and if we start at a higher level, by repeating things, you'll be like reaching that higher level very quickly. So I have seen that, Hiloni, that those students who join the classes, they improve faster than those students who work on their basic things by themselves because you're never having a schedule, you don't have a study partner, no friends, and you don't see anybody else who are studying hard. Okay, so that's the reason you go slow. But when you see other people in the group working hard and studying hard, that's when you increase your pace of study. That's when you improve fast. Yeah, I'm so sorry for that, Gladys, but hope you learned something from this class, or if you need any kind of help, let me know. Okay. How do I help someone out of practice for 10 years? Well, you know what? We had students who graduated in 1989. Okay. And I was born in 1987. So, and they were out of practice from a long time and they made it. All right. So don't think that if you're out of practice from a long time, you will have difficulty because what I've seen is those students who graduated 1 or 2 years back and those students who graduated 10 years back, when they start attending and start studying for NPT, both of them are at the same level. Trust me, I've not seen a huge difference because both of them don't know the concepts really well. Okay, unless they are like extra smart. That's right, Demar, Chris, that's right. Okay, all right, guys, so have fun. It was nice spending time with you all. And think about it. Let me know if you have more questions. Talk to us. We can definitely help you. Okay. All right, guys. See ya. Bye bye.